Good afternoon, everyone. Thank you so much to everyone for joining us today. This is going to be our final session of our interventional heart failure track. Again, I'd like to thank our speakers and our panelists for joining us from across the country. This last session is the heart failure shock to recovery session. So in keeping line with how the last session went, it seemed like it was better for us to skip the Q&A and save all the questions for the discussion. So to make sure that all of our speakers have ample time to get through their cases, we are going to save Q&A for the very end. And please, if anybody in the audience has any questions when it comes time to discussion, please just raise your hand and we can come over and bring you the microphone so you can ask our guest speakers. I'm also joined by my special co-moderator, Dr. Murat Fudim, had to leave early. So this is myself and Dr. Molly Silkowski from MUSC, both IHF trained specialists. So for any women in the room interested in IHF, there's two right on stage. So let's get started with our first speaker, Dr. Afzal, who's speaking on state-of-the-art cardiac recovery after severe heart failure.
Thank you. Thanks for the invite. Okay, well, so these are my disclosures, and the topic I'm going to be discussing today is about from severe heart failure going into recovery. So I'm going to make a case for recovery. So I'm going to start off with a case. This is a patient I saw about 4 years ago. She's 57, history of asthma, hypothyroidism, history of COVID myocarditis, who essentially presented to a sister facility in a stage D shock, rapidly progressed to stage E on the transfer to coming to our institution. And at that point, she was on 0.9 of epi and 0.7 of levofed, 0.4 of vaso. Her lactic was 25. Her MAP was 50. It was pretty impressive because I never thought we could titrate these drips at that high of a dosage, but here we were. So she ended up getting put on ECMO in the ER, and we took her to the OR and put a CP impella in for venting. So used the impella configuration. Our thought was this might be giant cell myocarditis because she was having a fair bit of arrhythmias before she went into stage E shock, so we started her on steroids. And going forward, over the next few days, we were able to get her off of ECMO, get her to a 5.5 impella. Her renal and hepatic function stabilized. She did have some complications from the line that was placed at this outside facility. So had a hemothorax, had to get a washout, things along those lines. But we were starting to go towards the consideration of transplant. And we talked at the transplant committee. However, she started showing hemodynamics getting better. And we started noticing that her EF had started looking better on the 5.5 impella. Long and short of it is we were able to successfully wean the impella down, and you could see that her cardiac output was getting better. And by decreasing the performance level, we were able to get her off of the impella, and her EF completely recovered. Biopsy showed lymphocytic myocarditis, and now she's back to normal activities of daily living. So what is recovery? Recovery is heart failure with recovered EF, which is essentially a documentation of an EF that dropped below 40% with a 10%, more than 10% decline. And then what recovery would be is a 10% absolute improvement in EF with a second measurement of EF of more than 40%. And these are typically accompanied by a reduction in your LV end diastolic dimension as well. And so what are the biological determinants of going through a recovery process? So typically when you have LV remodeling, it's because you have some sort of a structural change in your cardiac myocyte, you have change in your extracellular matrix, and then the chamber properties change, right? So your LV size goes up, your EF declines, you start seeing some valvular disease come up. And a lot of this is because of the impaired calcium handling. And so when we use a mechanical unloading device, you start seeing that it gets better with mechanical unloading. So if you start doing some physio studies in terms of beta receptors as well as calcium handling, it gets better. So typically when you have heart failure, your myocyte cell surface beta receptors go down-regulated. When you put them on an unloading device, whether that's a durable support device, and now more studies are being done on the temporary unloading devices, you see an upregulation of those beta receptors come up. And that's kind of essentially the idea behind recovery. And so what is the epidemiology? So most commonly, you need to look at the phenotype of the patient that's coming in the severe heart failure or cardiogenic shock patient. A lot of times, you will notice that the greatest rates of recovery is based on the phenotype. So typically a myocarditis patient, like the one I presented, typically has an 8% chance of full recovery. Postpartum cardiomyopathy encompasses almost 4% of the recovery patient population, as well as adriamycin-induced dilated cardiomyopathy. So these are typical common phenotypes where you see recovery, and need to kind of think of that as with the primary focus on it. Some of the clinical factors you need to think about in terms of recovery is the shorter heart failure durations of less than 5 years, non-ischemic cardiomyopathy, younger age patients, patients that don't have a very dilated LV, so typically less than 6.5 centimeters, and then that they don't have massive end organ dysfunction, so like typically their kidneys are relatively preserved in terms of function. So it's very important for us to rapidly up-titrate their guideline-directed medical therapy, and also when they recover, it's important to continue their guideline-directed medical therapy, and that's what the TREAD-HF trial showed, which is they did this phased withdrawal of drugs to see if patients have worsening of their heart failure function, and what they saw is that there was doubling of BNP, there was some worsening of heart failure symptoms, but no mortality, and so that was the conclusion, was that do not stop your GDMT. You also want to modify your risk factors. You want to get the multi-generational family history to make sure that you are making sure that you're ruling out some genetic cardiomyopathies as well. And why does this all matter? Is because this is what we as a field need to focus on. Our metrics are generally skewed. We are focusing on how many advanced therapies we're doing, whether that's LVAD or transplant. We don't really ever count the number of recoveries we're accomplishing, because that is a bigger accomplishment than anything else. And as Dr. Hall is going to talk about some of the status listing changes and things along those lines, what we have noticed is that we are not giving as much time on temporary mechanical support devices nowadays as we used to, and so we don't see as much recovery happening on the listing as well on patients that are actively listed, and this paper was published about 3 years ago as well. So to conclude, understanding the pathophysiology behind decompensated heart failure phenotype can help us risk stratify patients for recovery. In this era of having durable and temporary mechanical support devices and focus on advanced therapies, we should never forget the goal of ultimately achieving recovery, because that's going to have the best prognostic value for the patient, and that should be our marker of success. I'll open up for questions.
Thank you so much. We're going to move right into our next talk. Dr. Molly Silkowski will be discussing a decompensated heart failure to shock case. Take it away, Molly.
Hi, good afternoon. Thank you so much for this opportunity to speak. I am currently an interventional cardiology fellow at MUSC, where I also did my advanced heart failure training. And so with that, I have no disclosures because I'm still in training. So I have an interesting case that we had last year. So this is a 40-year-old female with a past medical history of ulcerative colitis, stable on mesalamine for years, who originally presented to an outside hospital for chest pain, tachycardia, and non-productive cough for 1 week. On arrival, her physical exam was essentially unremarkable. She just had tachycardia, but otherwise was hemodynamically stable. Her labs were notable for a BNP of 3,000 and a high sensitivity troponin of 700. Her EKG at that time showed sinus tachycardia, low voltage, and ST depressions, and she had a CT-PE that was negative for PE. For that, she was started on treatment for an NSTEMI, and she was transferred to another outside hospital. While she was there over the next few days, she had further cardiac evaluation to include an echocardiogram that showed a preserved ejection fraction with just a trivial pericardial effusion, a negative stress test, and then a cardiac MRI that was suggestive of myopericarditis. For this, they started her on colchicine only. They were concerned to do NSAIDs with her history of ulcerative colitis, but she had improvement with colchicine. Over the next day or so, she had increasing nausea and vomiting with mild hepatocellular derangement in her LFTs, for which they, quote, gave significant fluid resuscitation. We've seen this song and dance before. Shortly after that, she had increasing shortness of breath, for which a rapid response was called for hypoxia, requiring 2 liters nasal cannula. Her rhythm changed to an accelerated junctional rhythm, and she underwent another CT-PE that just showed a subsegmental PE in the left lower lobe. Echocardiogram was done at that time, and this has significantly changed from the first echo that had preserved function. As you could see, there's biventricular dysfunction here with the right more than left. And it was at this point that she was transferred to our center. On arrival, her labs were notable for a lactate peak of 11.2. She was immediately taken to the cath lab where we did a right heart cath biopsy. Apologies, the vitals on top show a heart rate of 78 and a blood pressure of 94/72 with a mean of 79. This is while she's on dobutamine 5. You could see that her right heart cath was suggestive of biventricular elevated filling pressures and a very low cardiac output of 2.3 with an index of 1.3, again, while on dobutamine 5. To further evaluate this, it shows that she was severely clamped down. Her SVR was 2100, and her RA to wedge and PAPI were showing that she had severely reduced RV dysfunction with a RA to wedge ratio of 1.13 and a PAPI of 0.33. And then her cardiac power output, again, while on inotropes, was 0.4. At this time, we had a shock call, and it was determined that she would be cannulated for ecpella. And during this time, that's when her biopsy came back, and you could see the dense lymphocytic infiltration concerning for fulminant lymphocytic myocarditis. Over the next 7 to 10 days, we attempted to wean her off ECMO with the assistance of inotropes. However, she did not tolerate this hemodynamically. And it was at this point where we determined and decided that she should have an advanced therapies evaluation. We, given that she is female and she had 3 children, we of course evaluated for antibodies, and her PRA was 100%, and not even small MFIs. Her class 2 antibodies have MFIs all the way up to 35,000, so deeply sensitized. So the challenge is how do we successfully transition a young female with a family, mom of 3, and biventricular failure who's not a transplant candidate? How do we get her home? So we ultimately implanted an LVAD for her. This is about a month after she initially presented. We did have an upfront surgical RVAD that over the next month we were able to slowly wean off. And once it was removed, she came out on normal pressors and inotropes from the OR with epi 0.02, dobutamine 5, and inhaled nitric of 20 parts per minute. However, over, again, the next days, 2 weeks, we were unable to wean her from inotropes. So at that time, our plan was to move forward with HeartMate 6 durable VAD in the RV. This decision took place over weeks. We have to get the family on board. She was shocked. Again, she was priorly healthy, and this was a very big team effort. While this was happening, of course, she's going to have nosocomial complications. So there was a concern for infection as she was fevering and had elevated white blood cell count, for which broad spectrum antibiotics were started. The antibiotics led to complete agranulocytosis. Her being severely neutropenic led to actual infections of Enterococcus faecalis bacteremia, pseudomodal pneumonia. The antibiotics for that led to dermatomyositis and a complete morbilliform drug reaction for which she was not able to participate with PT. And to top it off, she had herpetic oral ulcers that were so painful and she couldn't eat, leading to reduced nutrition. So significantly complicated. So with this, we decided, all right, let's get her to a place where she is stable medically with IV inotropes, send her home with IV antibiotics, let her recover, bring back for the surgical RVAD. However, she was developing worsening signs of RV dysfunction to the point where she was essentially severely presyncopal with any exertion because she had 0 RV to LV transit, and this is her echo at this time, and you could see her RV is completely akinetic and dilated. So what we did was we waited for the blood cultures to clear and for her to remain completely afebrile. She underwent a HeartMate 6 with a durable VAD in the RA to PA on April 23rd. She went aggressive rehabilitation afterwards, and she was discharged essentially 2 months afterwards. And again, she initially presented to the hospital 6 months prior. This is her echo after the HeartMate 6. You could see in the RA in the top right corner that that's where her inflow cannula is. This is her, she was just seen in our clinic a few days ago. So x-ray with her HeartMate 6, her drive lines are looking great. And for those heart failure doctors out there, you can see these are her VAD interrogations. The LVAD is in the top left. It looks like our typical VAD that you would see, a few PIs, but otherwise no significant low flows. And our RVAD is completely unremarkable. So key learning point from this is with fulminant myocarditis, early temporary mechanical support is key to lead for myocardial recovery and preservation of end organs. HeartMate 6 is rarely used, but viable surgical option, especially for those who are not transplant candidates. And in those with mechanical support, it's a team aspect. It's not just cardiologists and cardiothoracic surgeons, but it's also PT, OT, dietitians, and family members as well. Thank you.
Thank you, Molly, for that great HeartMate 6 case. We're going to move to our next speaker. Dr. Pham is going to be speaking on a case of biventricular failure.
Sorry, for full disclosure, I'm not an advanced heart failure doctor, so I didn't know if I was allowed to sit up here. But so my talk's actually really more about RV failure and kind of what to do in this particular situation. I thought it'd be an interesting topic, maybe generate some discussion, and love to hear from you folks. So, let's see, next slide. There we go. For my disclosures, so patient 77 has proximal atrial fibrillation, non-obstructive coronary disease, and hyperlipidemia, as well as wild-type TTR amyloid. Recent admissions for decompensated heart failure and secondary to severe TR. He's on ursodiol, doxycycline, dapagliflozin, and then sequential diuretic therapy with torsemide and metolazone, as well as emplerenone and tafamidis. On his EKG, he's in slow AFib with a left bundle and some frequent PVCs. So really briefly for his history, he was diagnosed in 2013, his cardiac amyloid with a cardiac MR as well as endomyocardial biopsy. And then he ended up getting a mass spec which confirmed wild-type pattern. Initially treated with doxycycline and ursodiol. He was at one point evaluated for a transplant, but I think given his age and his comorbidities, he was thought to be a prohibitive candidate. And then I believe 2 to 3 years ago, he was started on tafamidis with some improvement in his overall NYHA class symptoms. But unfortunately, this year has been kind of rough for him. He was admitted in January for a recurrent heart failure. EF is now 40%. And then on top of that, he ended up developing slow AFib. Our EP colleagues tried to place a dual chamber with BIV pacing, but unfortunately, for some technical issues as well as anatomical challenges, they were only able to place a single lead ICD. They adjusted his diuretic therapy, but it was prohibitive due to worsening AKI. Unfortunately, after a long hospitalization of, I think, 40-something days or so, he was discharged to acute rehab. He came back 3 days later for recurrent symptoms. And then on subsequent echo, surface echo, they found torrential TR, severely dilated right atrium, and then even worsening RV function. So that's kind of where I came into play. They consulted our structural heart team for evaluation of possible tricuspid valve therapies. And as part of our standard workup, we get a transesophageal echo. I'm not going to go through all the images, but clearly you can see reduced RV function. Here's the mid-esophageal 4-chamber with 5+ TR. And then here's the RV inflow view with the pacemaker lead going through it as well. And then our transgastric with and without color. You can see on the right, there's clear TR going through the entire coaptation plane. So not just around the lead, which seems to be relatively mobile, doesn't really contribute much to the pathology. And then as part of our workup, we also do right heart cath. As expected, he has elevated right and left-sided filling pressures and pulmonary artery pulsatility index just slightly over 1. Here's on the right-hand side, the right atrial tracing, consistent with the restricted pattern. So, with limited experience for amyloid patients, we're a pretty high-volume TriClip center, but this is probably going to be our first patient that we treated. Looked into the literature. There's very limited data for TIR for these patients. Our European colleagues published a case series with 8 patients with some success. They showed that it was safe and feasible, and there was some reduction in TR as well as improvement in clinical status. What they did note that the clinical improvement was slightly less than patients that did not have amyloid. And then even going further, are there valve replacement options for this patient? Unfortunately, or fortunately, there are options for standard patients. Trick valve is an early, has some positive early results, and then Evoke is currently the only FDA-approved valve for severe TR. Unfortunately, for this particular patient, there's really no published experience, to my knowledge, for cardiac amyloid. And so, after a lengthy heart team discussion, the patient underwent inotropic supported diuresis again. He had a long hospital course as well, just like your previous patient with E. faecalis bacteremia. And then, there's a lot of back and forth, but ultimately, we decided on discharging him with some increased optimal medical therapy. And again, as one would say, we're doing the same thing, he comes back with the same issue. So, we then decide family is now more amenable to this palliative approach. I won't go too much into the details of the tri-clip procedure, but we ended up putting a clip down the mid-AS leaflet with some modest reduction. We put another XTW clip down central AS. There is still some 2+ TR, but there is some question about whether we're going to sort of eliminate all of the low impedance pop-off valve of his RV. And this is the MPR results. So to conclude, he ended up with a successful TR procedure. We were able to reduce his TR from 5+ to 2+. He was sent home 5 days later. And for the past 5 months, actually, now, he's not been readmitted. I saw him in clinic recently. He's doing relatively well. And then repeat TE at the time showed durable 2+ TR and stable clip position. So, recognition, I think we're all appreciating the diagnosis of cardiac amyloid. Medical therapeutics are improving, as we know with tafamidis and other biologics targeting the mRNA of the tetramer. But we do see a lot of these patients with severe TR and MR, and there's not much data to guide us. So one thing to consider is TEER. It may be more suitable than valve replacement because you get the incremental TR reduction and that real-time assessment of RV function while you're doing it. Thanks.
Wonderful. Thank you, Dr. Pham. Our next speaker is Dr. Nikos Diakos, who will be speaking on microaxial flow pump bridge to transplant.
Thank you very much. Thank you for the kind invitation. This is a case of microaxial flow pump as a bridge to transplant. I have no disclosures relevant to the topic. This is a 67-year-old gentleman that has a history of chronic systolic heart failure due to ischemic cardiomyopathy, prior CABGs ×3 and bioprosthetic AVR a few years back. And he initially presented to an outside hospital with symptoms concerning for a stroke. His MRI was negative. He continued to have stroke-like symptoms, and the workup included an echocardiogram that, as you can see here, shows a pseudoaneurysm corresponding to the inferior wall. That was confirmed with a cardiac MRI, and you can also see layered thrombus over there. And the patient was transferred to our hospital for further management. So on day 0, he undergoes pseudoaneurysm repair. The surgeons also decided to put a venous graft to his LAD because the previous lima he had to the LAD was feeding like a septal branch. And he exited the operation room with a balloon pump, dobutamine 5, and vasopressin 0.04. And that was his baseline hemos. In post-op day 1, he develops a hemodynamically unstable VT, and he required cardioversion ×2. And unfortunately, as the course was going in post-op day 2, he started becoming more hypotensive. He required addition of inotropes and vasopressor. We added epinephrine, norepinephrine. He continued to be dobutamine, vasopressin. Despite those who have rising lactate, reduction of his urine output, and these are the hemos that we got. Of course, we took him to the cath lab, shoot the course, and you will see now the venous graft to the LAD is down, and there's occlusion of the native LAD also in the right-sided picture. So we have now a patient on the cath lab table with refractory shock, post-cardiotomy shock, actually, and he requires escalation. So the questions we have is which type of hemodynamic support will we choose, and what would be the exit strategy? And usually there is an interplay between those two questions, and the answer to one question can define the strategy to the other question, and vice versa. So in terms of support, depending on whether you support both ventricles or just the left, you have the option of ECMO, peripheral versus central cannulation. You can also pick some combination of bipella or impella plus protect duo that would allow patient mobilization. If you go for just LV support, we have the option of balloon pump, impella, or tandem heart. And with regards to the exit strategy, of course, we have to think bridge to recovery. it's probably unlikely in our patient with this reconstruction of the LV, baseline bad substrate with ischemic cardiomyopathy and big MI on the anterior wall. Other options would be bridge to durable LVAD, bridge to transplant, or of course palliative care. So we have a very unstable patient on our table. Our thought process was, how about we stabilize the patient, we put him on VA ECMO, keep the balloon pump for venting, with a goal down the road to transition to a bigger support for the LV, like Impella 5.5, and try to win the ECMO so that we can decide which of the following exit strategies we're going to follow. Indeed, the patient was placed on VA ECMO, balloon pump was kept for venting, and then in post-op day 3, we arranged for OR placement of Impella 5.5, and we were able a day later to progressively win the VA ECMO and decannulate. So now we have a patient on Impella 5.5. He's now extubated. Of course, we talked earlier in this session, we're always checking for recovery. Day 12 of Impella support, no signs of recovery. And we were running into issues. The patient was delirious, could not participate into decisions. Thankfully, he started recovering his mental status. Impella gave us the time for him to recover his mental status, to participate in decisions. He was able to mobilize. And then we decided to move for listing him for transplant. Is the Impella the best platform to list for transplant? What are our data? So comparing Impella with balloon pump, it seems that less patients with Impella are making it to transplant. However, the caveat in this study was that Impella patients were much sicker, so you cannot really tell if there's a difference. The 2-year outcomes were comparable after transplant. Patients bridged to transplant with Impella 5.5, they have better hemodynamics profile. They end up having better end organ function. They're 88% ambulatory and acceptable side effects. In this study, about 90% of the patients listed with Impella 5.5 for transplant, they made it to transplant, and there was almost a 90% survival at 1 year. And what about patients supported for more than 14 days? This is a recent paper came out. About 60% of patients presenting with cardiogenic shock made it to transplant, being supported more than 14 days with a mortality of 20%. So our patient was listed for transplant in post-op day 53. He underwent successful transplants after 78 days of Impella support. Actually, this happened last week. This is like the echo of the transplanted heart. He got his first biopsy this week, and as you can see, microaxial pumps have been used more frequently as a bridge to transplant with the new allocation system. Impella 5.5 seems to be a safe platform. More than 14 days can be a safe option in specific cases, and patients seem to have a very good outcome after transplant if they're bridged with Impella 5.5. Thank you.
Thanks so much, Nikos. Our next talk is going to be by Dr. Tony Carnicelli from MUSC, speaking on post-LVAD RV failure.
Good afternoon, everyone. Thank you to our wonderful moderators for inviting me to do this session. I'm going to talk in 5 minutes about post-LVAD RV failure and present to you a case of a gentleman that had a relatively recent and unfortunate ICU stay. So this patient is a 75-year-old male. He had mixed ischemic and non-ischemic cardiomyopathy and chronic kidney disease. Kind of an interesting story of mixed cardiomyopathy. He has ischemic heart disease with multiple prior PCIs several years ago. And he has no non-ischemic heart disease as well, with biopsy-proven sarcoid with heart, lung, and skin involvement that he had been treated for over the past couple of years. No major recent flares and no electrical complications from his sarcoidosis. He was very well for many years. He was actually an avid runner and quite fit and healthy despite his unfortunate heart disease. And then in early 2024, he was admitted for shortness of breath, kind of worsening heart failure symptoms, was diuresed, started on GDMT, and then had several more of these admissions until March of 2025, when he was admitted and then transferred to my institution at MUSC for advanced heart failure therapies evaluation. This is his eGFR trend that you can see over the past year or so. Not great, especially if you're a heart failure doctor thinking about advanced heart failure. therapies, kind of bouncing between 30 and 50. He had one that eked over that 50 line, but predominantly in the 30s and low 40s. This is his echo on presentation to MUSC. Again, this is a gentleman that was actually doing reasonably well about 1 year ago. And you can get a sense as to why he's doing so poorly now. So he's in the hospital, and we're kind of doing his LVAD evaluation, and then he starts to decompensate, and you can see his serum lactate starts to increase from normal to 4.1 one day, and he just says, I'm feeling awful. So we sent him to the cath lab. He's got severely elevated right and left-sided filling pressures and a thermodilution cardiac index of 0.61. He had a 50 cc intra-aortic balloon pump placed while we kind of continued his LVAD workup. He's transferred to the ICU, and these are his numbers. He ultimately gets approved for LVAD, which we'll talk a little bit about in a moment, but these are his hemodynamics immediately before going into the operating room, going from oldest to newest, left to right. So on his way into the operating room, he's on milrinone 0.125, dobutamine 5. He's off nitroprusside, which he was on for a period of time. His right atrial pressure is 4, and his cardiac index was 2.2, albeit being on 2 inotropes and an intra-aortic balloon pump at 1:1. So he goes in and gets his LVAD, and this is what his RV looks like during his LVAD case by transesophageal echo. Not the worst looking RV in the world. It's kind of small. He's got a little bit of TAPSy there. Again, not the worst looking RVAD, but he comes out to the ICU, and his lactate just is persistently elevated, kind of 4, 5, 6, 5, 5. Like really can't get it down. And he's on a lot of support. Milrinone 0.375, epi, vaso, norepi. He's got MAPs in the 50s. His CVP is really high. His CVP to wedge ratio is quite high. And his cardiac index is persistently at 1.2. His LVAD's only at 4,800 RPMs. He's flowing 3.2, persistent post-PI events. So he's struggling. And so, after a kind of multidisciplinary discussion, including the heart failure cardiologist and cardiac surgeons, we decide to take him to the operating room for mechanical right ventricular support. And you can see here, this is his chest x-ray, where he has a right IJ Protect Duo catheter and a Centromag RVAD placed for RV support. So we kept him on his RVAD for 2 weeks with this Protect Duo RVAD in place. We kind of slowly weaned his support down to 2,000 RPMs, and then a brief turn down to 1,000 RPMs, which is kind of our general practice. And despite the fact that his RV here by chest wall echo does not look great, his urine output looked okay, his MAP was okay, PA hemodynamics looked okay, and so we said, well, let's try and decannulate him. He's a 73-year-old guy who's spent 2 weeks on an RVAD in the ICU now. And unfortunately, he rapidly decompensated from a hemodynamic standpoint, requiring him to go back to the cath lab that very same day, get the Protect RVAD replaced, and go back up on full RVAD support. So we kept him on for another 2 weeks, and then reattempted basically the same wean and removal. And he, unfortunately, this is with the Protect cannula still in place, and he unfortunately now has what looks like even worse RV failure compared to before. So this represents a challenging case of early RV failure post-durable LVAD implant. And there are a lot of different complexities in the management of RV failure post-durable LVAD implant. There are also a lot of different risk factors that have been identified over the years for RV failure post-durable LVAD. And here are just a number of them here. I like how these authors kind of present this as RV-centered parameters, PA catheter, hemodynamic-centered parameters, and then echocardiographic or imaging parameters that are all known to be risk factors for early RV failure post-durable LVAD. But when you look at all of these individual risk factors in this specific patient that we're talking about, he actually doesn't meet very many of them. All of the thumbs up green stuff that you see on the left up here, these are all of the quote-unquote protective factors against RV failure. He actually only had a couple of poor prognostic factors from an early RV failure post-durable LVAD standpoint, and you can see those in red on the right side of the screen. But these kind of like univariable type of models are of a limited benefit. So it's really kind of more of a multivariable approach when we think of prognosticating the risk for RV failure after durable LVAD. And there are a number of different calculators that we use. The Stop RV Failure calculator and the Euromax right heart failure score are the ones that we kind of use more commonly. And you can see many of these variables in these calculators are the same ones that I showed you on a prior slide. And when you type in our specific patient's risk profile or individual risk factors, you get a pretty high risk of RV failure post-durable LVAD for him. So 35% according to the STOP RV failure calculator, and quote, high risk according to Euromax. And so there's a lot here to talk about with RV failure, durable LVAD, but I think just in the words of a famous cardiac surgeon, just the RV is an insert your favorite expletive when you're talking about the risk of RV failure post-durable LVADs. Thank you, guys.
And next we have Dr. Esposito talking about a case of limb perfusion in heart failure.
All right, thank you, everyone. This is my last talk of the day. My only disclosure is that this is supposed to be a heart failure shock session, but I'm actually going to be presenting two cases, one of AMI and the other of heart failure. You can see both sides, but both of them require temporary mechanical support. So this first case is an AMI shock case, a 65-year-old lady who had no significant past medical history, presented to an outside hospital with STEMI. She was found to have significant multivessel disease, underwent aspiration thrombectomy of an occluded circumflex, and she also went bifurcation stenting of the left main, the LAD, and the circumflex, as well as a PCI to the RCA, so an extensive multivessel PCI. She was implanted with an Impella CP during the procedure, and her Impella was removed 2 days after her index event. Unfortunately, almost immediately after her Impella was removed, she developed right lower extremity ischemia, and that's where her Impella was implanted in her right femoral artery. Her leg became mottled, cold, and pulseless. She was intubated after they found a type B aortic dissection on her CTA. So she was transferred to us for evaluation by our vascular surgeons. This is the CTA that we got on arrival here. You can see what looks like the start of a dissection flap right in the mid-thoracic aorta, and we're following it down to the visceral aorta right here. And then you'll see it bifurcate into the left and right iliacs. And you'll see that there's very minimal flow that looks like it's perfusing into the right iliac, which was consistent with her exam. So you could see hardly anything here that's outflowing into the iliac. This is a 3D reconstruction. Again, you can see the left compared to the right. There's hardly any flow going into her right iliac. So she's taken to the OR pretty quickly with vascular surgery. She's still intubated, and they did some initial angiograms. You could see something waving at you kind of in the middle of that thoracic aorta, and it seemed like it was actually much more consistent with a thrombus than a dissection flap. So they did an IVUS, which confirmed thrombus. And they did a bilateral cut down and went in there, and what they found is poorly adherent thrombus starting in the distal descending thoracic aorta with extension to the abdominal aorta and the infrarenal aorta, and then complete occlusion of the right common iliac and the external iliac. So they performed extensive aspiration thrombectomy as well as a right leg for compartment fasciotomy. And she was transferred back to the ICU. She unfortunately developed ARDS requiring a trach, for which she is still being managed. And this is the before and after of her vascular procedure where they sucked out all of that clot, and you can see a pretty decent result on the right. This is a next case. This is a heart failure shock case. So a 61-year-old lady with known ischemic cardiomyopathy presented to our institution with anasarca and SCAI stage B shock. So she had a known established history of ischemic cardiomyopathy with a moderately reduced ejection fraction. She was also a total vasculopath, so she had known bypass surgery, peripheral vascular disease, diabetes, carotid stenosis with bilateral carotid endarterectomies, several other medical problems. On transfer to us, she was normotensive, she was satting well, her serum creatinine was nothing remarkable, but she had a mildly elevated lactate, so all again consistent with SCAI stage B shock. So she was diffusely anasarchic, so she was started on aggressive IV diuretic therapy, and unfortunately, she really wasn't improving. Her urine output was pretty dismal compared to the amount of fluid she had on board. So she underwent a Swan catheter replacement in the cath lab. You could see that she's got severely elevated biventricular filling pressures, a reduced cardiac index. We repeated an echo just to see if there was any change. She still had moderately reduced ejection fraction and very dilated LV. So she was transferred to the ICU with the PA catheter sutured in place and then started on inotropic therapy with dobutamine, and at the same time, an advanced therapies evaluation was opened. Unfortunately, during this process, while she was still being medically treated, she developed significant bradycardia despite escalating doses of pressors, and the plan for her was to go to the OR for an Impella 5.5 as a bridge to durable LVAD, as long as her renal function and hemodynamics improved. And this decision was largely based off of a CTA of her femoral vasculature, which showed multiple short segments of occlusive disease bilaterally. So femorals were really out, so the plan was for an axillary 5.5 as bridge to durable LVAD. So unfortunately, oh, did it cut off the top here? So in the OR, what happened? She gets to the OR, she's supposed to get her 5.5, and unfortunately they did a TEE right before they deployed the pump. And unfortunately, it showed that there was some mobile echo density on the aortic valve that they thought was consistent with a potential fibroelastoma. So we had to bail on the 5.5. And instead, she was implanted with a left axillary balloon pump as well as a temporary pacer. So here's her axillary balloon pump in place. 1 week later, she's still on medical therapy, but the balloon pump was weaned and removed at the bedside. However, unfortunately, she developed a rapidly expanding hematoma of her left chest wall. So you can see here on the left, she's brought into the lab, and you can see exsanguination in the left axillary, and left subclavian. So she underwent one covered stent, which is the picture in the middle. You can still see some oozing, and then eventually 2 covered stents, which she was left with. So there were still ongoing discussions after this regarding a bridge to durable LVAD. She was unable to wean from pressor support. Unfortunately, she developed a bacteremia. She required intubation for hemodynamic instability and shocks, which I think she had on her way to get her LVAD. So that was aborted, and then she eventually developed cardiac arrest a few days later that was unable to be resuscitated and expired almost 2 months after her initial admission. So what are the key takeaways? Well, we know that acute limb ischemia complicates MCS and cardiogenic shock, and that's irrespective of shock etiology. So on the left are all comers with shock, in the middle is our heart failure shock, and on the far right is MI shock. So what we're seeing is that acute limb ischemia is not uncommon. So even with a balloon pump, which is the green shaded bars, balloon pump's only 8.5 French, but we can see for all comers with shock, there's still a 4% incidence of acute limb ischemia with just balloon pump alone. And this number escalates all the way up to around 8, 9, 10% when you upgrade to a 14 French with an Impella. So something to certainly be aware of in these patients. Acute limb ischemia is also associated with mortality, actually almost doubles mortality in shock, regardless of type of shock. This is data that was published by the Cardiogenic Shock Working Group. Again, looking at all comers with shock on the left, you can see that mortality increases from 30% all the way up to 60% when patients are diagnosed with acute limb ischemia. And limb ischemia is important. Not only does limb ischemia threaten the leg or the arm itself, but it's also associated with increased mortality in these patients, and you need to act quickly because irreversible damage occurs only 6 hours after the onset of limb ischemia. So just to wrap up with some of my conclusions, ALI in the setting of shock is common, irrespective of type of device and irrespective of shock etiology. Causes of limb ischemia are not merely device occupying vessel occlusion, which I think is a lot of what people think about. You've got patient in shock who's vasoconstricted, you're putting this giant pump in, but it can actually include other mechanical complications, like in the one patient I presented, thrombotic occlusion, extensive thrombus, dissection, other things. In-hospital mortality doubles with the presence of limb ischemia, and early recognition and monitoring of the limbs of these patients supported with these devices may help reduce complications in the future. Thank you very much.
Thank you, Dr. Esposito. All right, next we have Dr. Khalif discussing ECMO bridge to transplant.
All right. Thank you, Michele, Murat, all the CVI organizers for the invitation to present. I guess I should start by saying I am not heart failure trained, so that's my number one disclosure. Apologies in advance. So I'll start off with the case. This is a 67-year-old man with an unknown past medical history who collapsed at home, witnessed by his wife. She alerted EMS and actually began bystander CPR. He was found to be in ventricular fibrillation. Shock ×3 in the field. ROSC was achieved, and he was brought into our ER at Allegheny General in Pittsburgh. That was his pre-hospital EKG. Subtle. Had, unfortunately, recurrent ventricular fibrillation in the emergency room, required frequent defibrillation. CPR was reinitiated. And we have an eCPR program at our institution in Pittsburgh, and so we activated what we call a level 1 VA ECMO alert, which alerts the interventional cardiology and the critical care team directly to the ER at the bedside, and we cannulated him for VA ECMO. So per our protocol, we go directly to the cath lab subsequently, where we perform coronary angiography. In this setting, we actually placed an Impella CP catheter prior to coronary angiography due to the presence of an LVDP in the 30 range, 36. So an IV Cangrelor infusion was initiated for antiplatelet therapy, and we identified a significant culprit etiology to his, cardiac arrest and cardiogenic shock, totally occluded LAD in the proximal segment, and thrombus involving the bifurcation of the left main. So pretty scary stuff. So we proceeded with, IVUS-guided PCI with aspiration thrombectomy. I won't bore you with the details of the DK crush, but it was an extensive percutaneous intervention that required bifurcation stenting involving the bifurcation of the left main as well. I'll skip you all the gory details there. Successful PCI performed with adequate resolution of the culprit lesion and the bifurcation of the left main as well. So post-intervention, this was, risk stratified as an out-of-hospital cardiac arrest complicated by acute myocardial infarction, cardiogenic shock. Now status post successful escalation of Acpella and PCI. His PA catheter hemodynamics in the cath lab were not entirely surprising for very low biventricular filling pressures in the setting of the massive blood loss that occurs with early escalation to large bore access, as we've seen in prior cases. His lactate was noted to be 15, so he was subsequently admitted to the surgical intensive care unit for further management. Targeted temperature was initiated at a gold temperature of 36 degrees, and we consulted our advanced heart failure colleagues in cardiac surgery for definitive therapy, heart replacement therapy. And so this is his echocardiogram on day 1. Notably, severe biventricular dysfunction, but thickening of that left ventricle, the septum, with what we thought to be some significant myocardial edema in the setting of his ischemic event, with no substantial LV recovery post-revascularization. The EF stayed about 20 to 25%. His lactate cleared over time, so his biomarkers improved and his hemodynamics improved with de-escalation of his pressors. He was awake and following commands, but as Michele just eloquently described, limb ischemia is real, so we quickly tried to de-escalate the large bore access in his groins. So we escalated him to an Impella 5.5 on day 2, extubated him, heart failure team evaluating him for heart replacement therapies. We performed percutaneous ECMO decannulation on day 5. He was listed as a heart transplant on status 2 on day 11, but he had a prolonged ICU course that was complicated by pulmonary edema, hypoxic respiratory failure, critical illness with weakness and myopathy, further complicated by aspiration pneumonia, small bowel obstruction, escalating antibiotic therapies, got re-intubated on day 16, the entire time on an IV Cangrelor infusion, which we came up with a pharmacy-guided, PRU, P2Y12 reaction unit monitoring to help facilitate escalations to the OR. Our surgeons do not like oral antiplatelet therapy going to the operating room. But nonetheless, he was considered too high risk for heart transplant therapy, and so he got a bridge to transplant LVAD on day 23 of ICU stay, extubated post-op day 3, and eventually was transitioned to apixaban and, warfarin and clopidogrel on post-op day 3. Discharged to inpatient rehab on day 35. So, thank you.
Thank you so much, Dr. Khalif. We're going to wrap it up with our final talk of the session, who I have to say, I didn't mention it earlier, but Dr. Shelley Hall is actually one of the original, we like to think, interventional heart failure cardiologists. So we actually have 3 of us on the stage, women IHFers. So in keeping with that theme, Dr. Hall is going to finish up the session here, and then we're going to go right into a discussion.
All right. Here we go. This is an interesting category topic for this session. So these are my disclosures. I guess the most important one is, as of July 1, I was the elected vice president of the National OPTN Board. So I expect the crying and the condolences later, because it's been an interesting 23 days. This is the transplant system, okay? And there's no way to cover this in 5 minutes. We're going to focus on how devices are impacting. And the first thing to understand is the allocation system is continually evolving and changing since the very first list was done in 1986. And it's about every decade there is a change. And the theme is the same. The top category fills up with people. It becomes survivor. Whoever survives till they get an offer wins, and then it gets so full that you have deleterious outcomes. And so when we did our current allocation, of which I was part of the heart committee and then the chair, is that we looked at everything that was in that highest category, which is, you can see on this table, it's devices. It's durable devices with complications, it's temporary devices, and spread out over their risk of death while waiting for a transplant, all in the same category. And therefore, what do? We look at that and we divide it into essentially tertiles, which is shown here, is that all of those different types of scenarios were divided up into 1, 2, and 3. So you can see in 1, the devices was VA ECMO, surgical non-dischargeable devices. Status 2, very eclectic group if you look at it. Total artificial heart, single ventricle with an LVAD, VTVF, balloon pump, and the temporary devices that we didn't really have a name for back then. We called them MCSDs. And then status 3 is honorary to a durable VAD, high-dose inotropes with a SWAN, and a lot of VAD complications. And that it was the bulk of transplantation, okay? So there were some very good things that came out of that. The first is that the time to getting a heart transplant plummeted. These sick patients were getting shots and living, and across the country, you can see from the blue to the green, marked decline in waiting. It also showed a decrease in waitlist deaths, and that was the objective. That's what allocation's all about, getting an organ to the sickest person, decreasing their chances of dying while waiting for an organ. There was a lot of cries that we were going to kill post-transplant survival. That was not the case. Both 1-year and 4-year survivals were identical to the previous era. But there's a dirty side to this, and everybody knows that I speak about this. So what happened is, as soon as the rules changed, we changed. And if you look at the top graph, the red line that just jumps right up at that break and continues to rise, that's status 2. That grouping I showed you that ranges from total artificial heart down to balloon pump. And if you look at below what that is made up of, it is balloon pumps or exceptions. And I'll tell you what exception is in a minute. It wasn't that we put in more total artificial hearts. There is a slight increase in Impellas. There was a slight increase in ECMOs, but not statistically much when you look at it. So exception is a boo-hoo story about why my patient doesn't qualify but should still be there. And I want that to sound harsh because we're doing that to our system right now. An allocation system just puts everybody in a line. And every time you ask for a skip up in the line, you're pushing everybody else back one, okay? There have been over 21,000 exception requests filed in the first 4 years of the allocation system. The allocation system is already 6 years old. So why is that? Well, the reality is our temporary devices aren't so temporary anymore. Nobody's going to bridge with an Impella CP. We all know the disaster of an Impella CP after 7 days. But balloon pumps, cheap. Oh, rotate around. They got extra vessels. Go to the left, go to the right. You know, oh, well, this one had to be ligated, so I got to put it in the groin and make you bed rest. But I'm going to keep extending you with that balloon pump because I don't want to put a durable VAD in. Or you go to an Impella 5.5, well-documented, great survival in Impella 5.5 for prolonged periods of time. In this, from the cardiogenic shock work group, up to 90 days. So our technology's improving. Our temporary devices are not temporary anymore. And we've gotten really good at how to manage these devices now. We're really good at anticoagulation, at aggressive ambulation, and ICU care in general. So the UNOS, now OPTN, we recognize that we can't have this race to status 2 and then beg to stay in status 2. So we created documents and changes to policy that you have to fail status 3 medical therapy before you go to a device. And that was approved in December of 2023. We're still waiting for that to actually be enacted because there is such a lack of resources to programming and getting these policies in place. We are now told that it may be this fall. Now, we're moving towards a new allocation system called continuous distribution. And I don't have time to go into that, but it'll be a point system rather than a category system. But if we put all of the statuses on this sort of curve, it allows us to break it up even more. So that status 2 with all those devices, say we did balloon pump, and we said balloon pump is not nearly as much support as a total artificial heart. So a total artificial heart should get all of those points, but maybe a balloon pump doesn't get, it gets a percentage of those points. And that's what continuous distribution does, is allow us to spread these devices out. Well, there's a new wrinkle, and if you're into this at all, I've spent my entire week, on Tuesday, 4.5-hour Senate Oversight Committee. I'm so glad I'm the VP and not the president who had to sit there and give his presentation. But politics have gotten involved, and now there's going to be this modernization of how we do transplant. I have no idea if this is going to be a good thing or an absolute disaster, because now politicians are catching on to a particular problem and making that the highlight of transplantation. So there's a lot that's happening, and there could be a lot of changes. The allocation system is always changing, but we have to acknowledge that we change when the rules change. The rules were developed based upon our old behavior, and then we change our behavior. We say that we're upset about this, and yet we're doing nothing to change our behaviors. We have to find a way to get away from the device we choose to the true metabolic illness of the patient, and we haven't figured out how to do that yet. And then the continuous distribution, well, I said it was 2 more years away. It's just been paused by HRSA because they want us to focus on some other things first that have hit the headlines, and so they want those things fixed before we move to continuous distribution. And no matter what we do, no matter what rules we create, there's still not enough hearts for all the patients being listed, and the allocation system just creates a line. It doesn't create more hearts. And I'm not sure that the modernization effort is going to improve our system, and it could markedly hinder it.
Thank you so much, Shelley. That was a perfect talk to wrap up the session. We're now going to open up the discussion, but unlike what we've done in the previous sessions, we really want to encourage audience participation. So I know that there's not any microphones on the floor, but if anybody has any questions, raise your hand and we can come around with microphones for you. Oh, awesome. Oh, you can, yeah, if you want to approach her, we can.
My question is about post-cardiac surgery RV dysfunction, that case that I think presented. What are the risk factors during the surgery that can lead to, whether it's post-VAD, post-cardiotomy, or post-transplant RV dysfunction? Because I mean, most of us in this room aren't advanced heart failure trained, but we keep seeing this. These patients have they don't have any right pre-transplant or pre-VAD right heart cath findings to suggest high risk for RV failure. Is this something to do with the cardioplegia that happens, inadequate cardioplegia, or hyperinflammation? Are there other non-hemodynamic risk factors that can predispose them to immediate or intra-op RV failure?
Yeah, thanks for your question. I mean, my disclosure is that I'm not a heart surgeon, so I can tell you what some of the literature says, but you know, as far as being there, you know, hands-on doing the operation, I think surgeons will often have their particular things that they're looking for: physiologic, anatomic, hemodynamic parameters. You know, the classic answer to that question, really, as you alluded to, I think, in your question, is hemodynamics going in. And so one of the things that we're always taught, of course, is right atrial pressure, right atrial pressure, right atrial pressure, and just making sure that the patient isn't going into the operating room congested. Although the patient that I showed you had a number of reassuring factors going into the operating room, there were a couple of unmodifiable risk factors that unfortunately don't have anything to do with the surgery. That's the renal dysfunction and the age. Those are kind of the 2 big ones. In the operating room, things that some folks have thrown around but haven't really borne out with regard to robust observational analyses are things like pump time is kind of a big one. Some people talk about coronary integrity, like right coronary artery disease, and whether that contributes to RV ischemia during the procedure that can be associated with RV dysfunction. Pump time is really kind of the big one, and congestion. I think those are the two that most cardiac surgeons will talk about. I don't know, Dr. Hall, if you have anything to add to.
I agree. One surgeon's approach is one surgeon's approach. And usually it's a black box. For us non-surgeons, it's a black box in the OR. We're told when they're rolled back to the ICU, everything went great. You read the operative report, and everything says great. You try and dig and interpret the anesthesia records, and you're like, wow, they had a lot of drips. And half the time they don't record the pushes of epi they gave and all that. You never find out about those. So unless you're in there in the OR, I don't think we really ever truly know what happens in the OR. What we do know is the RV is very vulnerable to vasoplegia, persistent hypotension, acidosis. And so to me, it's very meticulous anesthesia that can make or break your RV survival coming out of the OR. And that's very variable.
I also will, I'm so sorry, go ahead.
One comment to make. Yeah, I totally agree with what is said. For that particular case, and I've seen it at least 2-3 times this year, and I think it's anecdotal. When you see these like gigantic spherical LVs with less slivering-looking RV, we put them in our MRBs and we're saying, oh yeah, that looks kind of a good RV, but I think you trick your eye also by the fact that the LV is gigantic and the RV is like sliver-like. So I don't know if by acutely unloading with the LVAD, you shift the septum and these are more vulnerable. But I've seen it a few times that we say, oh, this RV looks kind of okay, what happened? But, I've seen when the LV is gigantic compared to the RV, sometimes, you see that. And of course, the pushes, as we say, the OR and whatnot, and how much epi they got. I try to get, when I'm on service tray, and I know a VAD is coming out, I try to get, mid-case scene and kind of glimpse what they are doing in there and what the TE looks like. And then, you get the backstory from anesthesia a little bit at that time. They tell you, yeah, we're coming off bypass, I pushed like 4 of epi and stuff like that. So you kind of get a gauge of what's going to happen.
And I think another thing is nothing that is iatrogenic, but it's just the pure, with anesthesia or anything, but the pure septal manipulation that occurs intra-op with placing the LVAD and just the geometry and losing that synchrony that the RV has with the septum has also been shown to lead to RV dysfunction.
One of the more interesting risk factors for post-LVAD RV failure, early RV failure, or that I think is interesting anyway, is that LV enlargement is actually a protective risk factor, so to speak, for post-LVAD RV failure. So there was a JACC paper that just came out like within the last year. Post-hoc, analyses and that kind of thing, observational, but LV enlargement, the bigger your LV, the lower your risk of RV failure. I mean, it's observational, not something that you can study in prospective fashion, but just kind of interesting.
I think the one thing is that we have to get our surgical colleagues comfortable with the fact that an RVAD is not failure. RVAD is good preventative therapy. And if that RV doesn't look robust when you're thinking about closing up, put an RVAD in. The literature continually shows if you wait till they come to the ICU and then, they get sick 24 hours later, the outcomes are far worse. And in the old days, yes, I was part of the old days, is that all VADs got RVADs. They all got temporary surgical RVADs in the beginning. And then that was felt to be redundant and didn't need it. And then we've moved away to now an RVAD is only if you fail. And so I think we have to break that stigma among our surgical colleagues. You'll see them debate all the time about, I never need an RVAD, and we need to get away from that. Because our patients are too sick nowadays going in for especially LVADs. There are a huge incidence of RV failure.
And Dr. Hall, going off of that, what are the parameters you follow to urge a cardiothoracic surgeon? Is it a PAPI of 1.85, or what do you use?
Well, I would like to say I yell louder, but everybody knows that's the truth. So I think part of it is coming to consensus before cases. So we created a RVAD placement protocol. Now, if they would just follow it, right? I mean, the reality is we sit down and over a neutral territory and we talk about data and we review and create criteria. And then they're in the OR and you're trying to point out those different things. They're like, oh, well, no, it's not that bad. Oh, look, really good. And then they send them out and we're there that night and then they crash and we're putting in bedside RVADs and we go and look up and they met our protocol. And so then, it's creating a unified criteria and then following it.
Dr. Hall. I think that, in your comments about the dose allocation system, that we're getting better as a group, both advanced heart failure, interventional cardiology, at these types of temporary devices, the bedside management, the deployment. Is this a call to action, sort of, that maybe we should rethink the paradigm of these patients post-LVAD surgery, to maybe go back to those days of where potentially we're talking about these smaller, more nimble devices in almost every single person, a select group of people, or broadening out that criteria, knowing that we can potentially support them and then wean those RVAD devices?
So I think there was a couple questions in there. So the first is, yes, we've gotten really good at managing temporary devices, and I think that we are going to be coming up with new terminology of intermediate devices because of how long we can keep these going. In the prior allocation system, we moved to LVADs because we knew that in that congested top category, many of our patients couldn't survive long enough to get a transplant. So we would talk to them and say, okay, we're going to put this swan in and we're going to put you on drips, but if we don't get an offer in 1 or 2 weeks, we're going to VAD you. Otherwise, you're going to get septic, something's going to happen, you're going to die. And they're like, okay, doc. Now, we have totally run away from that because if we can get them at that high category and keep them with exceptions and extensions, then we'll eventually bypass the dreaded durable VAD and get to transplant. The problem is, as you'd expect, as that fills and fills and fills, you get more and more people there, and the same thing is happening where the wait on those temporary devices is getting longer and longer, and you're having people die of vascular complications, of infectious complications, because they didn't want to go for the VAD. And one of the indications for continuing at a high status was contraindication to an LVAD. Well, the community, our community, is saying patient's choice is a contraindication to LVAD. And the original intent was they would drop down a status if they didn't pursue an LVAD, because those who can't physiologically get an LVAD would be disadvantaged. And that behavior's not happening because they're saying we're bypassing patient autonomy. But the result is we're jeopardizing people's lives.
Really was towards post-operative VAD management for those RV failure patients. Yeah, because we have slicker, more nimble devices, and certainly earlier recognition of post-cardiotomy, RV failure, post-VAD does carry a significant prognostication about being able to appropriately treat, escalate, and 12 hours, 24 hours later after this person comes out of the operating room and they're not doing well and they're limping along, right? I mean, we've seen a number of different papers that have come out that have shown that the earlier recognition and the earlier escalation of support leads to better outcomes in patients. So in terms of that comment, is this sort of a call to arms about potentially changing a paradigm about how we treat these patients instead of selectively reserving post-LVAD RV device therapy? Potentially, do we end up broadening out that population?
I think that they are definitely, the literature is saying we should. It's a matter of how do you move the speeding train?
Yeah.
And this community, our community tends to commit, and we commit. And we just keep on barreling. And so trying to move us takes a lot of overcoming inertia. And then you're talking about surgical inertia. Once a surgeon is comfortable in their behaviors, they don't like to change behaviors for the most part. So you've got two things that I think intellectually we can say yes, absolutely, but functionally making it happen is far more difficult.
Thank you for the presentation. My disclosure is I'm not a cardiologist at all, at least yet. I'm an internist. It's kind of like a double question. The first part is, I know there's even some work coming out of Dr. Diakos' lab, actually, about the recovery world they're using, some AI models for phenotyping and prognostication. One, is this something that you see is going to be a thing more and more into the future and be more incorporated into practice? And number two, Dr. Hall, do you think that this would eventually bleed into the organ allocation system, or are we not there yet? In the essence, to provide even more granularity into the curve you were showing us.
Yeah, I'll let Dr. Hall answer the second question, but I mean, I think the AI aspect of it is growing. It's new. I just talked to a couple of people who are working on the AI side of things right before this talk as well. So, I think ultimately we are going to look into data mining, right? Like finding patients that are possible candidates for advanced therapies through our health record system and identifying those phenotypes that should go towards recovery and trying to figure out which patient has modifiable disease factors, right? So it's ultimately phenotyping each patient. And I don't see any reason why in the next 3 to 5 years we could have like a risk prediction model based on each patient and have a scoring for them. Be like, hey, this patient has a higher chance of recovery or this patient has a lower chance of recovery. It's I don't think we have like just seen the tip of the iceberg as far as AI goes in terms of utilization in the health. I mean, in the health literacy and as well as in the data mining from the health record system. I think we're going to see patients getting identified earlier through the AHR system. We'll see patients getting referred to us earlier, ideally, and then also see more modifiable risk factors and prognostication values. So more to come on it, I think, and that conversation will keep.
Yeah, regarding allocation, we really got excited about recovery because patients were being forced into long device support, whether it be temporary or durable, and we go, well, wow, some people recover. To program that into allocation is much more difficult. Are we going to really say you can't list until you failed X weeks on an Impella 5.5, for example? That's going to be hard for the community to swallow, but it shouldn't be. Because right now, if we were to list for heart kidney, we can't list for the kidney unless they've had 6 weeks of dialysis during acute kidney failure. These patients come in sick, they're on Impellas, and then they lose kidney function. We can't list them for heart kidney for 6 weeks of that. So it's already happening in the kidney side. Why couldn't it happen on the heart side for certain categories, post-cardiotomy, myocarditis, some of those things? I think it'll be very difficult to pass, but it shouldn't be impossible.
Can I make a comment in that regard? I think it's very interesting because as we get better at managing devices and supporting people for longer, we're seeing more recovery, that's true. But on the flip side, I feel like increasingly when we get on the shock calls, we're doing this mini screen for advanced therapies before we decide to put an MCS device. And so then we shortchange patients who could recover, but they have like maybe a psychosocial impediment to getting advanced therapies, and we decide we're just going to give them a balloon pump. And that patient maybe with a 5.5 could have recovered over 6 weeks, but we're not doing it because now we're envisioning ECMO, 5.5, and even all MCS as a bridge to advanced therapies. And we say, well, if we don't have an exit strategy, we can't do it. And so we shortchange recovery in multiple ways.
Thank you.
Great conversation. I would say, by the way, for the shock comment is, the screen should just be for absolute red flags against you absolutely can't have advanced therapies. But bridge to recovery is a very reasonable indication for temporary MCS. But Shelley, I was going to ask you, or anyone on the panel, you're in Texas, so I think you guys rain hearts a little bit more than we do up north in Chicago. And so we won't really list the blood group O who can anatomically get a VAD who is unwilling to do a VAD. Because right now our wait, we have a skinny dude who's been waiting for 6 to 8 weeks. We're nowhere near. And he has kidney disease, so he has a good reason to get a heart kidney. But there's somewhere in between of saying patient choice doesn't matter at all, but also practically speaking, if we can't do a quote unquote bailout VAD before you get really, really sick, then we also don't always list those patients and say, hey, you have to be okay with the VAD, because otherwise you could be waiting and get sick and then die, And we've had that happen before, which is what made us pivot.
Yeah, I think, geographic variations are always going to occur. We're a large country with vast urban and vast rural areas, so there's lots of variability across the country in access to donors, because ultimately the donor to recipient matching is a distance and cold ischemia time thing. Transport devices are certainly improving that and expanding that, but they're not reimbursed, and they're bankrupting transplant centers right now. So I think that some of the inequities that you mentioned, we're trying to look at in the allocation, such as blood type. Blood type O is disadvantaged, and so that is expected to get more points in the continuous distribution compared to the other blood types, just getting everybody on the same playing field. There was a lot of talk early about population density, and what we call donor density is analyzing the donors produced per population to try and see if we could put that into the continuous distribution to try and make it more even. So if you were in an area that didn't get a lot of donors, you got extra points compared to places, just so that everybody was even. You'll never make it completely even. There's just too many variables. But I do think that we are going to have to limit the amount of time somebody can be on a temporary support. If they anatomically, physiologically can get an LVAD, otherwise those who cannot physiologically, even if they said a loved one, can't get it for whatever reason, they're being disadvantaged by those who just choose to, I don't like that thing, I don't want a driveline. But those are social decisions that our country is very uncomfortable making compared to the rest of the world, who very much makes those decisions for their citizens.
And I would hope as we, anatomical, the HCM patients, the restrictives, those are kind of easy, the congenitals, although there's some wiggle room there, but that's the easy. To me, I think, I hope as we make this system change and continually evolve, is we include things like kidney function, right? Like I actually we had a good dinner nerdy debate about this, right, with some of the Columbia folks, is that you theoretically could do a VAD, but the chance of a VAD dialysis is pretty high versus a heart kidney would be a much better option. Anatomically, that person can get a VAD. They're also not on dialysis. They're CKD. So I hope that factors in of post-transplant, post-VAD bad outcomes which is also really hard. I'm glad I don't do what you're doing. But I know you're at the forefront, so thank you for doing it.
Thank you, everyone. Thank you again to all of our speakers, our panelists. We really appreciate everybody, again, taking the time out to fly down to Austin to be here today. Great discussion. We hope everyone has safe travels back home, wherever that may be. And thank you again for wonderful sessions.